Hello everyone, welcome to day 6 of our challenges series. Today we will be covering from page number 86 to page number 97 from our subject of psychiatry. Just starting with general psychiatry, you just need to remember certain things of mental state examination, where you will be testing mood and affect of patient through the mental state examination. You need to remember fluctuations of mood, where there is emotional lability in mania. Affective flattening is seen in schizophrenia, where the person does not express his emotions, and also there is loss of congruency and appropriate reaction to a particular situation in schizophrenia. This is one thing you need to remember from mood and affect. Then you need to remember in perception, there might be a stimulus which is real stimulus is present and which is perceived as different, and there might be no stimulus at all. If there is no stimulus and yet the person is perceiving some object, then that is hallucination. However, there are two special kinds of hallucination called reflex hallucination and functional hallucination, where there is a stimulus in reflex hallucination, there is a stimulus in one modality and the person feels the hallucination in another modality. This is seen with LSD and cannabis. And there is functional hallucination, where there is stimulus in the same modality as the perception of the stimulus. And another important thing to remember is illusion, where the person is having the false perception of a real objects. For example, a person is perceiving pipe as a snake. So this is your classic example for illusion. That's all you need to remember from a perception. Then you need to remember in thought, there is something called stream of thought, where there might be flight of ideas in mania or slowing of thinking in other disorders. And then there is form of thought. You need to remember certain 2 or 3 important stuff in this. One of them is neologism, where the person makes his own words. Then there is loosening of association, where the person keeps on talking to multiple different sentences which has no association with each other when asked about a particular thing. And then there is something called thought block, where the person is not able to think about anything when probed about something. So this is some important forms of thought. Then you need to remember about content of thought, where there is delusion. The person feels that the person is not able to change his belief about something which is not socially or culturally explainable. So it is firm, and also it is not supported by any evidence scientifically. So the most important thing is the most common one, which is delusion of persecution seen in schizophrenia. Some important named ones you need to remember is D. Clermont, which is also called as delusion of love. Then there is Cotard, which is nihilistic delusion, and then there is delusion of infidelity, which is Othello syndrome. Then the most important thing is the mimic between Capgras and Fregoli, where in Capgras you will remember PYQ, where there is two mass, where a person, familiar person, is replaced by a stranger. That means that you have a similar looking stranger as dressed up as your wife. So that is so what to say, it's so challenging for the person. So Capgras is that, whereas Fregoli, a person is not able to identify his mom, for example, thinking that the familiar person has disguised as a stranger. So in Fregoli, the person thinks that his mom is someone like, so appearing like someone else. So this is one different kind of delusion of misidentification. These two important things you need to remember. And then there is possession of thought, where there can be insertion, withdrawal, or broadcasting of thought. And then there is obsession, which is the most controversial topic, which can come under both content and possession of thought. We would like to group this under possession of thought. Then there is PYQ between transference and countertransference. And then the PYQ on abreaction was catharsis. these two things you need to remember, you can't skip this. And then there is something called organic versus functional. So just remember that in organic you can't find anything on MRI or CT. You go to a radiologist, he will tell no, the person does not have anything, but actually the person has something that is seen, that is functional for in functional the person can't have any MRI or CT findings, and hence only a psychiatrist will diagnose such disorders. While you or on organic, the person, the radiologist will see something on CT or MRI. So that is the important thing you need to remember in organic versus functional disorders. In functional, the classical examples being schizophrenia, delirium, and mania. While organic, you can see that dementia, delirium, Wernicke's, Korsakoff's, all of them have some imaging findings. Okay, other than that, you need to remember the timelines of psychiatry. You just need to remember some important timelines. The most important ones I would ask you to remember is ADHD from in childhood disorders. Just remember ADHD for a duration of 6 months, specific learning disorder for a duration of 6 months, and oppositional defiant disorder for a duration of 6 months. Other than that, selective mutism is for a duration of 1 month, and separation anxiety disorder is also for a duration of 1 month. So S and S comes under 1 month. However, specific learning disorder comes under 6 months. In eating disorders, most of them come under 3 months: bulimia, anorexia, and binge eating. Okay. Then again, in somatic symptom related disorders, somatic symptom disorder is more than 6 months. Just remember these things. And in mood disorders, which is the most important one, you need to remember that major depression and major depression with peripartum onset, both of them come for 2 weeks. Phobias, illness anxiety and generalized anxiety are grouped if are categorized when there is duration of symptoms for more than 6 months. And then for less than 6 months, however, for adjustment disorder comes under less than 6 months. Panic and PTSD are for 1 month. All your P's, panic and PTSD are for 1 month. This is some important ones you need to remember, and for schizophrenia you can remember when we talk about schizophrenia later. And all your sleeping disorders also are grouped if categorized if the duration of symptoms is greater than 3 months. Then there is neurotransmitter changes and neuroimaging, which you can study. That is not that important. Just remember that schizophrenia has increased dopamine, Alzheimer's has decreased ACH, Huntington has increased dopamine but decreased GABA and decreased ACH. These 3 things I would suggest you to remember. Parkinson's you will know by the action of the drugs. Anxiety and depression are not that important. Just remember that norepinephrine plays an important role in anxiety where there is elevation of norepinephrine while it is decreased in depression. Other than that, there are about 40 psychotherapies. You won't definitely remember even if you study that for one complete day. Just remember some important ones, like CBT is the most important one, used in treatment of your eating disorders, anorexia and bulimia nervosa, depression and PTSD, where the patient is thought to recognize distortions in their thought processes. Okay, so the person also for example, if there is an alcoholic, he will recognize the trigger for alcohol consumption, so he will prevent himself from drinking alcohol whenever he feels the trigger to do so. This comes under CBT. Then you have to remember behavioral therapy, where the person has to change his maladaptive behaviors or reaction to the stimuli. For example, systemic desensitization is a type of behavioral therapy and for use for treatment of phobia, specific phobia. Then there is important things like dialectical behavioral therapy is a group therapy used for a borderline personality disorder. Then systemic desensitization, as I've told you already, for specific phobia. And then there is one more important thing called EMDR, eye movement desensitization and reprocessing, which is used for treatment of PTSD. And then there is one more important thing called aversive therapy, which you already know, used for substance use disorders and for sexual paraphilias. Other than that, you have your important ICD classification from F0 to F9 for organic disorders mainly, and there are F10 to F19, like so on for till F79. The things we will be covering today will be dementia, delirium, and substance use disorders. So in dementia, you just need to remember two important stuffs: cortical versus subcortical dementia. So cortical basically means all your imaging findings will have some atrophy or related changes in the cortex. Consider this as your ventricles and this as your interhemispheric fissure. So all cortical changes in cortical dementia you will be seeing. These include Alzheimer's, Pick's disease and Creutzfeldt-Jakob disease. In subcortical location, however, be it your basal ganglia or related stuff, if there are changes on CT MRI, then that is under subcortical dementia. This also includes cerebellum and brainstem, basal ganglia and thalami. Okay, so in cortical dementia you have your three important stuffs: Alzheimer's, Pick's and CJD. So an amnesia will be more severe, and one important thing will be the presence of apraxia, agnosia, aphasia or calculia, depending on the involvement of that specific lobe which has these functions. Personality is preserved in most of them except when frontal lobe is involved. Just remember this thing. However, in subcortical dementia, the personality will be gone. The person will have less severe amnesia, but there is slowness in alertness. So that thing you need to remember. And these people also have associated movement disorders and depression, more common than cortical dementia. In subcortical dementia, we have your Parkinson's, Huntington's, multiple sclerosis, Wilson's disease, hypertensive dementia, normal pressure hydrocephalus, and supranuclear palsy, TSP. So some important reversible causes of dementia also you need to remember. Two important stuffs I would like you to remember is your metabolism related, this is vitamin B12 and niacin deficiency and hypothyroidism. Also transient illnesses like infection, hemorrhage or toxin related. Then NPS is also associated with reversible cause of dementia. So certain keywords which we have given in our notes, you just need to remember every keyword for each specific dementia category. LPD will present with a visual hallucination with fluctuating cognition and syncopal episode. Alzheimer's, early onset, insidious in nature, short-term memory loss with later it will develop into personality changes. Parkinson's, however, will have recent tremors, bradykinesia, rapid progression with hypo and hyperkinetic symptoms. Vascular dementia, just remember again slow progression but in a step-ladder pattern. Suddenly it will progress, then it will remain stable for some time, again suddenly progression and remain stable, so on. With executive dysfunction happening early. In frontotemporal dementia, as the name suggests, frontal lobe will be involved. There will be disinhibition. The person starts having personality changes. Other than that, just remember that memory is affected last in frontotemporal dementia. So next important thing, as I've already told, memory is affected less in your subcortical dementias, but this one being a cortical dementia, memory is affected lost. Then you need to remember in B12 deficiency, the person will have all your megaloblastic anemia and other peripheral neuropathies and stuff. Tertiary syphilis presenting patients will have ataxia and loss of pupillary reflex. NPH will have your famous Hakim's triad, that is dementia, magnetic gait, and urinary incontinence. Wilson's ring, Wilson's disease, a patient will present with KF rings, liver disease or dysarthria, sometimes with encephalopathy. CJD will present with myoclonus and history of beef consumption or anything if it is different variants of CJD. Then you need to remember moving on to the next important thing, which is delirium, which is an organic disorder with acute onset. Whenever you see an organic disorder with acute onset, it is delirium. Important stuffs you need to remember about delirium is the clouding of consciousness and your disorientation and memory deficits. Other than that, EEG will show generalized slowing in delirium, except alcoholic and benzodiazepine related withdrawal related delirium, where there is fast wave patterns. Next important stuff you need to remember is the treatment for delirium. You have to treat the etiology. Many etiologies I have given. Two important stuffs in diagnosing delirium are your sundawning phenomenon, which might be given in the question, along with clouding of consciousness and something called flocculations with autonomic disturbances. These are important stuffs you need to remember. Next, you need to remember your substance use disorders, where I'll be talking about under certain categories like depressants, then stimulants, and then hallucinogens. So we'll start with depressants as of now. So under depressants we have your barbiturates, benzodiazepines, opioids. So all your depressants, basically when intoxication happens, there will be obviously mood elevation, anxiety, sedation and other stuff. However, when there is withdrawal, again there will be anxiety, tremor, seizures and insomnia. Just remember, barbiturates and benzodiazepines both have a different receptor. Barbiturates acts on its direct GABA modulator, positive modulator. However, benzodiazepine binds to a separate site and hence acts as an allosteric modulator. So whenever there is intoxication, you need to remember for barbiturates, you have to manage it symptomatically. There is low safety margin and respiratory depression. And whenever there is intoxication of benzodiazepines, because of the greater safety margin and presence of lumefantrine, which is a specific antagonist, you will have better prognosis. Withdrawal, however, both of them will present with delirium along with sleep disturbances and seizures. So just remember these stuff. Other than that, opioids is one important thing you need to remember. Whenever there is activation of mu receptor, there will be pupillary constriction along with all your mnemonic based things which you remember: decreased GI motility, respiratory and CNS depression, euphoria and decreased gag reflex. This is one of the most common cause of overdose death, the opioids. You have to treat it with naloxone. Opioids, you treat it with naloxone when in case of intoxication. However, in case of withdrawal, you treat it with methadone or buprenorphine. Next, remember some important things about alcohol withdrawal. Just Widmark's formula is not asked nowadays. Just remember alcoholic hallucinosis, alcohol auditory hallucinosis. Okay. Other important stuff you need to remember is your breath alcohol testing is based on Henry's law. Some important methods I mentioned there. Treatment for alcoholic withdrawal. First is to symptomatically detoxify it. So the drug of choice will be benzodiazepine, which is you give a long-acting benzodiazepine so that it does not have drastic effect on the receptors. Then you have supplements with thiamine and vitamin B complex, as most of them usually present with malnutrition. And in case of Wernicke's, you directly give IV thiamine in 5% glucose. Remember this. IV thiamine in 5% glucose. Whenever there is a case of Wernicke's, you just need to remember this stuff. Then you have certain anti-craving agents like disulfiram, where they have a classical question: what does it inhibit? It inhibits aldehyde dehydrogenase, not alcohol dehydrogenase. Remember this. Then you have your naltrexone, which is also opioid antagonist. It decreases craving, and acamprostate, which is an NMDA antagonist. Then you have your stimulants, where intoxication and withdrawal causes certain important symptoms which you need to remember. You need to remember a point or two about smoking cessation. What will you remember in smoking cessation? The nicotine replacement therapy comes in patches, gums, and lozenges. Then you have a bupropion, not buprenorphine. This is bupropion, where it reuptakes norepinephrine and dopamine receptors, blockage of them. Along with that, there is something called varenicline, which is a partial nicotinic receptor and agonist, and hence it limits withdrawal symptoms. So remember one important controversy: whenever varenicline and bupropion is given as the most important or the best alternative for alcohol withdrawal, varenicline, however, is superior to bupropion, but bupropion must be considered in patients with weight gain and or coexisting depression. So read the question carefully and what they expect you to answer among varenicline or bupropion whenever they ask the most important drug or the drug of choice for alcohol or for smoking cessation. Sorry. Then you have your important stimulants: amphetamines, caffeine, cocaine, and nicotine table, where they have mentioned the treatment for everything. Amphetamines, you treat it with benzodiazepines. Whenever there is symptoms related to amphetamines. And withdrawal, you need to remember for amphetamines, there is something called meth mites. And you have your acute and protracted symptoms. And in caffeine, you need to remember the important action is through adenosine receptor antagonist. Then you have your cocaine, where you have on intoxication something called Magnon symptoms, which is important, where the person presents with formication or tactile hallucination. Chronic use will lead to nasal septal perforation. Treatment is again with benzodiazepines. Then you have one more important thing for nicotine, which I have already told, replacement therapy and the symptoms for that. Then moving on to the last part today, the hallucinogens. What do you remember under hallucinogens is three important drugs: LSD, cannabis, and MDMA. There's one more important drug, phencyclidine, which is not tested that frequently. So LSD is a 5-HT2 serotonergic receptor. Cannabis is has a separate cannabinoid receptor, CB1 receptor. Then MDMA acts on monoamines, serotonin, DAT, and norepinephrine receptors. Then you have your NMDA receptor agonist, which is antagonist, which is phencyclidine. So one important symptoms you need to remember: everything causes euphoria and some hallucination of some sorts. LSD is associated with bad trip. Cannabis is associated with perception of slowing of time. Ecstasy is associated with disinhibition, bruxism, some life-threatening effects also. Phencyclidine is associated with impulsivity, some important symptoms which I mentioned among all the symptoms. So these were the important topics for today. We will move ahead with study these topics well. All the best.